All right. So I am introducing Dr. Martin May, who most of you know. He's going to be talking about a whole bunch of stuff about kidney transplant. So we're going to go into organ options, um, wait times, multiple listing, and some stuff about antibodies. Okay. So I'm going to turn it over to him. Take it on, Dr. May, and thank you for doing this for us.
Well, thank you.
Mm.
Um, so do me one favor, Pat. I've tried to share it.
Oh,
I need some permission,
okay. Hang
or I can send you
on.
my PowerPoint.
Now I can get you. Hang on a second. Go ahead. Okay.
Let's try it one more time. There we go. All right. So I'm going to, as Pat said, we're going to hit these issues, which really, in a whole, and I'm going to kind of introduce you to how this kidney offers happen, uh, what control the transplant center has, what control you have in making selections in an effort to get a kidney transplant and hopefully one that meets your needs. So organ options, wait time, multiple listing sensitivities, or what we're going to refer to as CPRA are all important issues in you making a choice of what kind of kidney will meet your need. So I've changed the order around. So this is kind of the outline that I'm going to follow. But I first wanted to go through what happens on our end and what you will see on your end if this process works. So the kidney offer timeline basically starts when a donor has been identified. In that process, an organ procurement organization is called out and they review the medical history. They'll review the laboratory, all the imaging studies that have been done by the team caring for the donor. And usually at this time, in the majority of the organs, the donor will be declared brain dead. There are donation after cardiac death, which we will address. This would be someone that would not have any meaningful recovery, and the family decision based on the personal preference of the donor are going to let the donor pass away, but the heart has to stop before you can use that donor. So this process is part of what the information is gathered by the OPO. If the OPO checks off all the boxes, they can be offered to a recipient, then this information is uploaded into a computer program called UNET, which is run by the United Network of Organ Sharing. And all this clinical information is placed into that chart. And once the donor information is found, and know that if you're approved for transplant, you're on this list, they have all of your characteristics, blood type, of your preferences. And by the way, and I'll get to this in more detail, transplant center's preference of what organs we're willing to take. And a computer generates a match list. So what the match list is let's say the donor is blood type O. It's everyone with blood type O that would be compatible with this kidney. And it runs it first, looking for perfect matches nationally. And then it starts with matches within a kind of geometry of concentric circles around the donor hospital. So it's not donor hospital to where you as the recipient lives, it's donor hospital to where the transplant center is. So geography has some meaning. I'll get into that a little bit because that's a major change that just happened in the last year and a half. But that's how this list is generated. It has a number one on the list. It has maybe 2,000 on the list, and each patient has a transplant center assigned to them. So in part, this match list depends on the proximity of the donor hospital to the transplant center, the time on the list of the patients that are on the list, the matching or HLA, which I will discuss in more detail, of the recipients. So potential recipients waiting on the list get points for time, they get points for matching. And then the transplant center is allowed to add filters, meaning if it's an 80-year-old donor, maybe some centers will take a fling at that. I can tell you Mayo Clinic wouldn't accept an 80-year-old deceased donor. So we would filter any offer for 80-year-old, and I would never see that donor. But if I was a center that accepted 80-year-old offers, then you would see them. And then the important part of this talk is you also have some options that allow us to filter the kidneys to meet your needs. And that's, to be honest, the crux of this. But all of that is now in the system. A kidney becomes available, it generates a match list. So for every new organ that comes in, there'll be a different match because different matching of the HLA, different filters depending upon the actual donor themselves means that there's going to be assigned a different priority for each of the patients. And when that match list is generated, electronic offers are then made to transplant centers. So this all happens online. At Mayo Clinic, we're blessed to have a lot of procurement coordinators that around the clock, so 24 hours a day, are glued to their computer screen looking for offers. These coordinators that we have working for us not only take kidneys offer, but the liver, the lung, and the heart. So they're very busy and they work around the clock. And know that on this match list from this donor that's being offered, we may have the first patient on the list, or our patient might be number 200 on the list. But we're going to make a decision then based on what we see of the medical information, the lab, the imaging. Do we want to accept the kidney for this patient, whether they be number 1 or number 200? And those choices then are made. And depending upon, every transplant center gets a certain amount of time to enter their answer. And then the match list is refined to the centers that will accept the organ, and it'll go to whoever is number 1. So literally the kidney might travel or begin the travel to that transplant center as they are calling in their patient. And on our side, if we've said yes and we now hear that the kidney may be coming our way, then we're going to have our procurement coordinator contact that patient, getting answers to questions. Have you been in the hospital? Any new problems? Any current infections? That sort of thing. And they get that information from the potential recipient. And then the coordinator in turn provides logistics to the potential recipient so they understand where we are, when the decisions are going to be made, when they might have to come to the hospital. They'll also provide information in how long it may take them to get to the hospital. And then any questions are answered, particularly about details of the kidney. This all happens with this phone call. So once the kidney is assigned, then the hospital that has the first patient brings their patient in. If this patient is too sick to be transplanted, then the kidney is offered to the next patient, and that may very well be a different hospital. And now this hospital is on the clock to get their patient to come in to see if they're healthy and can accept the transplant. And so it's not unusual for the kidney literally to be sitting on ice while several different recipients at different transplant centers in a region are all being called in, and they decide whether the patient's healthy enough, medically suitable to be approved for the kidney. And if they are, then the kidney is offered to that patient. But be aware that while that works out, the kidney's sitting on ice because it's usually been removed from the donor and it's waiting to be surgically placed into the recipient. So if our patient was number 200, then number 1 through 199 have either coded out the transplant center wasn't comfortable taking the kidney, or they've brought the recipient in and they're not medically cleared for the surgery, so the kidney goes back to the pool and is offered to the next patient. So eventually at 200, the kidney might come to us, but that kidney then may have been on ice for 24 hours before the kidney even arrives here. Now, that's not a bad thing necessarily, but the earlier we put kidneys in, generally the quicker they work. So we're all cognizant that the sooner that we get it in, the better. Everyone in the business is aware of that. So everyone is trying to do this in a very expeditious manner. And importantly, when we bring our patient in, we again address issues that were discussed by the procurement coordinator on the phone are now addressed face to face, discussing what the kidney, what the information that we can reveal about the kidney, which I'm going to cover in detail. Any risks to that kidney are covered. And then, of course, we're doing blood tests, X-ray, EKG to make sure there's been no other changes, doing a physical exam. And as long as the patient has had no change since they were approved, they'll be medically cleared. And be aware that still doesn't mean you're going to get the kidney, because you'll be placed toward the operating room, but not put to sleep until the kidney is visually inspected by the transplant surgeon. So they literally they what they call back table work. They take it out of the igloo in a sterile fashion. They're going to inspect the kidney to make sure it structurally appears sound. And if it all is good, patient's been medically cleared, patient's put to sleep, and the transplant happens. So, at Mayo Clinic, that happened 220 times last year, but I can guarantee you the process actually happened a lot more times than that, because we bring in a lot of patients that ended up having some medical issue or a new problem where we felt the risk of pushing on through the surgery was too great and they got sent home without the kidney. So just be aware that that can occur. So that's the background. And it introduces the idea that the transplant center has some issues that they can control on what kidneys they're willing to accept, but so does the potential recipient. And that's really the crux of this talk. So we're going to start with the first topic. It's called wait time. And when you're applying for kidney transplant and you're meeting someone at the transplant center for the first time, it's very reasonable to ask how long it takes. Be aware that it's important to know your blood type, because the wait time is different for each blood group. And at Mayo Clinic, for example, currently the wait for an A is typically 3 years. B and O are typically 5 to 6 years. AB is 2 to 3 years. So that's how do we determine that? We look at who's been waiting the longest on the list. And in general, the longest on the list for A is around 3 years, B 5 to 6 years, etc. That's how we determine. These numbers are not static. They do change with time. They can get better, the shorter wait, they can get longer. It all depends on organ availability and how many people are on our wait list. And then importantly, there are choices that both the transplant center and you can make that can shorten this time. And some of these choices may involve some risk, but I'm going to try to convince you that almost always this risk is so small that the benefit of the transplant, in particular getting off dialysis, is always worth it, is going to be my take-home message. But I'm going to try to convince you of that by moving to the next topic. So we have an average wait time that you're aware of. And one of the things that will affect your wait time is not only your blood type, but what we referred to as your sensitivity. So CPRA is calculated panel reactive antibody. So antibodies are good and antibodies are bad. So HLA, or human leukocyte antigen antibodies, are bad in transplant. So human leukocyte antigens, or HLA, are little proteins on all of our cells. They're labeled as class 1 or class 2. And these proteins are assigned alphabet names: A, B, C, D, R, D, P, D, Q. And they help our immune system figure out what is us and what is them. and them being bacteria, viruses, some cancer cells change their proteins. And our immune system, when they go by like a policeman on the beat around the block and they're circulating through your blood and your tissues, they're shaking hands with every cell, making sure that these HLA proteins match what they are supposed to be. And if they don't match, they try to kill that cell. All right. So when you make an HLA antibody, it's an antibody that will attack other human tissue. And these antibodies are formed when you get exposed to human tissue by way of a blood transfusion, having a baby, because although baby is half mom, the baby is half dad. So there are different HLA proteins on the babies. And then, of course, any prior transplant, you're exposed to someone else's tissue, and an antibody may form that can damage tissue that matches those proteins in the future. I must make you aware that occasionally infections can generate an antibody that also reacts against human tissue. So rarely infections can also form HLA antibodies, not directly against human tissue, but they happen to co-react. So those antibodies are bad. And we do CPRA measurement. We've actually determined if you've had the antibody measured at each transplant center. Do know that the antibody levels can change with time. Each center picks off a cutoff number. We measure a number, and Mayo uses 2,000 as the cutoff. Anything higher than that, that's a bad antibody. We have to avoid the protein that that antibody is directed to. Anything less than that is probably safe. The antibody is not likely to cause harm. And these HLA antibodies are listed on the transplant registration. And we're going to avoid kidneys that the antibody might attack. So whatever that protein target, that A, B, C, DR, DQ, DP, whatever the alphabet is, that's the antibody. We're going to list that as an unacceptable protein. And if the kidney has that A2 and you have an antibody against A2, that's not a kidney you can accept because it will reject literally on the operating table. So this helps us match you, and be aware that having a really high CPRA, which is a bad thing, a lot of antibodies, it means you're going to react to a lot of people. So literally, this is a percentage. It's a good estimate of how many of our donor population you will react to. So if your CPRA is 50%, then you're going to react to 50% of the donor pool. If it's 90, you react to 90%. And in those circumstances, it means on the 50 side, you can accept 50% of the donors, they'll be okay. On the 90% CPRA, you can only accept 10%. So the higher the number, the longer you wait. But importantly, in general, the cutoff is here somewhere around 80. All right. So a CPRA below 80 generally is not going to affect your time. CPRA above that will have some effect, but it really doesn't magnify until you hit the 98, 99, or 100 CPRA level. Importantly, the new allocation system gives you points for your CPRA, but the biggest benefit where you get added points to get a transplant faster is in that 98, 99, and 100 group. And that increases your matching locally for 98, regionally for 99, and nationally for 100. So if you have a CPRA of 100, you are literally being tested for every kidney in the country. So even if there's a kidney in Seattle, you're listed with a CPRA of 100, but this is the one out of 300,000 kidneys that would match you. They will send that kidney to Florida. You would have enough points to bypass everybody else. So it's key for you to know your CPRA. It is a test that every transplant center does. And I mentioned that in general, anything below 80, not likely to have much of effect. And in general, it's only the super high numbers of 98, 99, or 100 where we're going to have major challenges trying to find you a kidney. I will point out one other important thing, that patients sometimes misconstrue, and that is I mentioned that blood transfusions can increase sensitization, meaning you are exposed to someone else's tissue and you might form an antibody to that tissue, and that will make it harder for us to find a kidney. So we do like to try to avoid blood transfusions, but never avoid a blood transfusion if it is a life-threatening situation. Always say yes to that. And in general, any hemoglobin below 7, no transplant center will tell you not to get transfused. The risks are too high. Avoiding the transfusion, you should take the blood. So that's one of the things that we can talk about. Again, this is one of those set facts. The numbers do change. Your antibody levels might fall, they might rise depending upon circumstances. But the key is you want to know that because it can help you decide if this antibody level is really high, you may want to really consider some of these alternative kidneys to try to get transplanted because you need a bigger pool of kidneys to find the one that you're going to be compatible with. One other quick and easy thing is multiple listing. And I say it's easy because it's easy to explain, but I'm not going to say it's easy to go around to a bunch of different transplant centers trying to get on their list. But I will point out that because geography matters in transplant, the more transplant centers you're listed at, the better opportunities you have to find a kidney and the quicker you will get transplanted. So I mentioned at the start that they changed the allocation system. Rather than being in the organ bank territory, they now assign concentric circles that, let's say, are 250 miles around the donor hospital. And the first dibs on that kidney are any transplant centers within that 250-mile circle. They then go to a 500-mile circle before they're offered on a more regional or national level. So again, if you're listed at multiple centers, it can help get you transplanted quicker. And this geography matters used to create a huge discrepancy on how quickly people get transplanted. So historically, Florida has been a state where we get a lot of donors, a lot of people willing to give the gift. In other states, not so much, and people wait longer in those states. This new system of concentric circles was trying to decrease that disparity, to try to equalize the geography difference throughout the country. It helped a lot. It still didn't eliminate it altogether. And that's why it's still worth looking if you have the insurance that will cover other transplant centers, if you have the time and the money to travel to other transplant centers, listing at multiple centers can be beneficial. I will make you aware that if you're at Mayo Clinic, if you're approved here in Florida, and you're interested in being listed at Mayo Clinic Rochester, Mayo Clinic in Arizona, you just need to let us know. It'll take a week or two. They'll present you at their committee. You don't have to go there. They have access to our chart. We're all on the same record. You'll get approved. But if you then get called by Arizona with a kidney, you've got to travel to Phoenix. They will not send the kidney to Florida. That is not allowed. So you got to go to Arizona, you get the kidney, you hang around Arizona for a month. When you come back to the Florida area, we're happy to pick up where they left off. And I would also say, if you want to go to Emory, you want to go to Orlando, we're happy to share our workup. It's not as automated because we're separate practices, but almost every transplant center will accept the workup of other transplant centers. Be aware you do have to repeat the blood typing, the tissue typing, and you have to meet their multidisciplinary team. Those are rules written in stone, so you can't get away from going to the center, but they can often minimize it to a 1 or 2 day visit. So that's multiple listing. Again, ways of trying to get transplanted quicker. So it leads us to the biggest area where you have input, and therefore understanding these options, very important in making decisions of what to do next. And we're going to start by talking about the types of kidney as far as brain dead donation versus cardiac death donation. And we're going to talk about an important score that you need to know about called Kidney Donor Profile Index. So at the top of this slide, we have DBD, or donation after brain death, versus donation after cardiac death. So let me kind of share what I'm talking about. I'll use me as an example. So if I have a bad car accident going home tonight and my brain gets injured so severely that I have no brain activity, my EEG is flat, I am brain dead. They will declare my death at that time. My heart's beating. They know I want to be a donor. I signed my license saying as such, and they will start my workup. And then if they find a donor for any of my old organs, then they will end up taking me to the operating room with a beating heart because I'm legally dead, and they'll remove my organs. That's different than if my accident has a subtle difference. The brain injury is severe, but I have minimal brain activity. It may be the very primitive part of my brain that has activity, meaning the rest of my cortex, my personality, my ability to talk, none of that's coming back. It's irreversibly damaged. If I survive, I might have to have a ventilator. I'll be the quote vegetable, meaning there's no meaningful interaction with me. I don't want to live that way. My wife knows I don't want to live that way. So if the conclusion of my treating team is I don't have any potential recovery, but I'm not brain dead, then they're going to withdraw the breathing support and I actually have to stop breathing. My heart has to stop. And for every hospital, it's a different amount of duration. And once my heart stops, they declare me dead and they can take me to the operating room and remove my organs. So there is a little difference in the early kind of outcomes between brain dead and cardiac death donors and kidney. And the difference is you need dialysis about 30% of the time for the brain death kidney, whereas you need it closer to 50% of the time for the cardiac death kidney. But if you look at the long-term access, 1 year, 5 years, 10 years, that success, that outcome, no difference. So as long as it's everyone's on page, a little more dialysis and DCD, but still at least 50% of the DCDs kidney works right away. And because the long-term outcomes are equivalent, we as a group don't look at these any differently. So we don't ask your opinion on whether you want one or the other. We let you know when you come in. You can always say, no, I don't want that. But because we look at them as equal, that's something that you need to be aware of. And I would not suggest sticking just with one or the other. I would end up being open to both because this is going to increase your access to transplant. So that's the first thing here. The second thing is KDPI. So this score is trying to give you some information on the success outcome of this kidney. So it's based, the Kidney Donor Profile Index, or KDPI, will be reported to you when you get the phone call, and it's based on 10 donor characteristics. So that includes the age of the donor, whether they have diabetes, hypertension, of course, their creatinine, how their kidney is doing. That clinical information is put into a complicated equation and it spits out a number between 0 and 100. And that number gives you details of what we call the half-life of the kidney. So if the score is between 0 and 85, this is referred to as a standard kidney. The half-life of that kidney is between 9 and 11 years. Half-life is the point in time where half the kidneys are working, half of them aren't. So on an average of 10 years, some kidneys may have failed at year 1, some year 5, some year 10, some year 15, some year 40. This just gives you a kind of a benchmark of how this kidney will work. And it's an important difference between the 0 and 85 kidney versus the greater than 85 kidney, where the HL, or half-life, is 5.5 years, roughly half as long. So there are some KDPI greater than 85 kidneys that will last as long as any lower KDPI. But more likely, because it's coming from an older donor, the higher the KDPI, the older the donor, but the number is not the age, all right? We don't use 100-year-old kidneys or 90-year-old kidneys. So These kidneys are older donors, and because of road wear, scarring, whatever, kidneys not going to last as long. So my 66-year-old kidneys will not last as long as the 25-year-old version of my kidneys. So you might say, well, geez, I never want one of those. They don't work as well. And for a lot of people, that's the best decision. But importantly, if you have certain medical problems, you have a lot of calcium in your vessels, a lot of heart disease, both of them may get worse as you wait. You have a lot of antibody where you need a bigger pool to try to find a kidney. You're having trouble with access on dialysis, or dialysis is just hurting you every time you go there. For those folks where they have less time, where their transplant window is open, KDPI greater than 85 is a beautiful thing. So no matter how old you are, no matter what your health, even a KDPI greater than 85 kidney, even if it only lasts 5.5 years, you get a big survival benefit compared to staying on dialysis and waiting longer for a standard kidney. But if you're young and healthy, there's no reason to take a KDPI greater than 85. But if you're older or have some of these other medical conditions that are more likely to change with time, where your transplant window will shut, then this is something to get transplanted, and it may actually prevent that problem from happening. So, key thing to remember. Next options deal with infections. So importantly, as I go through each of these infectious options, be aware that, of course, we test everyone for hepatitis and HIV. And in most cases, the donor is going to be negative for both. I've given you some examples where that's not true here. But in most cases, that would be true. But remember that you cannot detect HIV or hepatitis C until 7 days after the exposure. So if I go shoot up with my HIV friends tonight, you're not going to see my test turn positive until next Wednesday. So if my car accident is on Sunday night and I didn't tell my wife I shot up with my HIV friends tonight, then she'll swear I'm an angel. My test for HIV will be negative, but it'll be a false negative because it's only 3 or 4 days after my exposure. But if you had waited till Wednesday, you would have seen the infection. And that's the scenario where you can still get HIV or hepatitis from the donor. So I don't want to overstate this risk. These are really low risks. So I can tell you the numbers suggest that HIV risk is like 1 in 100,000. All right. So the risk of getting hit by lightning today as it storms is about 1 in 20,000. So this is a really rare event. So rare that I've done this since 1985, not seen that scenario where a test that was negative for HIV gave someone the infection. So can it happen? Yes, but that's very rare. So my message here is there is no zero risk kidney. And so each of these risks are higher than that lowest risk, but I'm going to try to convince you that the risk is still so low and the benefit of the kidney is so high, would encourage you to say yes to most of these. So I've given you an example at the top. Hepatitis B core antibody positive kidney is a kidney from a donor that's been exposed to hepatitis B but currently doesn't test positive for it. So they may have very low level of hepatitis B that can travel with the kidney and cause infection. And if we transplant those kidneys into someone protected by the vaccine, they're protected by the antibody, there have been 0 reported cases of hepatitis B in that scenario. So if you're successfully vaccinated, this is an option for you, and I say it's a no-brainer. The second choice deals with the 2 hepatitis options. One is hepatitis C. AB is antibody positive. NAT is nuclear amplification testing negative. So the antibody means they've been exposed, but the NAT is the actual test for the virus, and they test negative. So in a lot of hepatitis C, it can actually disappear on its own. It doesn't always go away, but it can. This individual may have been exposed and now they cured themselves, or they may have been exposed and they got some of the new antiviral medicines. The virus is gone, but the antibody remains. This is one option for hepatitis C. And the other option is if the NAT, the nuclear amplification testing is positive, this is for the virus itself. This means the virus is present in the blood and in the kidney, and that's the higher risk of these two options. In the first, the antibody positive, NAT negative, when we've transplanted that, we've been blessed, been using these kidneys for 5 or 6 years, haven't seen any hepatitis C, and those people do not get treated unless they develop the hepatitis C, versus the hepatitis C NAT positive, they will get hepatitis C, and therefore we have a special regimen, 8 days of therapy, and everyone's been cured. No one has continued to have hepatitis C. And indeed, in the transplant world, they've been using these kidneys since 2015. No one's reported a failure to be cured of the hepatitis C. So no one can ever promise anything in the future other than we're all going to die. All right. So if you are unlucky, you're the first one that was not cured of hepatitis C. The downside is that in 20 years or so, you may develop cirrhosis or liver cancer, but it's usually not a virus infection that hurts you right away. And again, the track record thus far, 100% success. And then lastly, this group, donors meeting risk criteria for HIV or hepatitis, previously known as public health service increased risk donors. This would be the prostitute that has a car accident, the drug overdose, the person that dies in jail. When you're in those scenarios, you're around HIV and hepatitis more. And therefore, even though the donor tests negative for HIV and hepatitis, the chance that we miss the infection is higher in this group than it would be for me if I have my car accident tonight and my wife says I don't do any of those things. So the key here is that that risk, although higher, is still really, really low. So for example, I quoted 1 in 100,000 risk for the HIV in a low risk individual. This would be a higher risk individual, one that uses, let's say, IV heroin and died of an overdose. Your risk of getting HIV in this negative donor, we missed the infection, would be 1 in 10,000. So you might say, geez, that sounds really high. It's 10 times higher. But I already mentioned, the risk of lightning is really rare at 1 in 20,000. When you have a surgery for the transplant, any surgery like for tonsils, you have your appendix out, your risk of dying of the anesthesia is 1 in 3,000. So when you have the surgery, you have a higher risk of dying than you do of getting HIV or hepatitis from the donor. Because these risks are so small, strongly would encourage you to say yes to these donors. They tend to be younger, so it doesn't mean they will be. There's old farts like me that still do drugs and stuff, but I'm just mentioning that they tend to be younger. The quality of the kidney tends to be better, and these behaviors don't affect kidney function. And so would be a good option to say yes to. Do they do HIV transplants of HIV positive kidneys into HIV recipients? They do, but they can only be done under an IRB approved study protocol. They had one at Mayo Clinic a number of years ago, but that is no longer active. So we transplant HIV recipients, but with HIV negative kidneys. So those are the infections. 2 other options I'll briefly touch on. Dual adult kidneys is the first. So occasionally we get a donor and they're older like me, maybe in their 60s, and the creatinine, mine currently is normal, but let's say it was like 1.6, so a little high. And we, as a transplant center, looking at that kidney offer, and we say, we don't think 1 kidney's enough. And there are now strict criteria, and the organ bank offering the kidneys can offer twofer. So they'll offer both kidneys. And if we take both kidneys, we give you enough kidney function, but you're going to have both kidneys put inside during the transplant. So dual adult kidneys, not a common operation, but that's something that, again, would readily say yes to if offered. And we would describe it, it's obviously 2 kidneys going in, a little longer surgery, but the outcome should be excellent. Similarly, when the tragedy happens when a youngster is declared brain dead and is a donor, then to get enough kidney tissue until the kidneys grow, we may take both the pediatric kidneys, or if we're using one pediatric kidney, be aware that your creatinine will average a little high right now, but that kidney will grow with time. And as the kidney grows, the creatinine will fall, and the outcomes are excellent for both. But do be aware with pediatric kidneys, because they're coming with smaller arteries, a little higher risk of kidney clotting problems. So these are other alternatives that we as a transplant center decide whether we'll offer these kidneys, and then they will be discussed with you if that's the scenario. So a lot of different options, a lot of things to talk about. And why do you want to make these decisions? So I mentioned, geez, it's a 3-year wait for blood group A. That's my blood type. And I'm 66. I don't have kidney failure today, but let's just imagine I did. I'm on dialysis because I'm going to show you, using me as an example, some numbers here to help you make decisions. But the key here is I'm showing you an old slide, and in the past, I would say the numbers are better today, but because of COVID, these numbers are actually slightly worse. But they're basically a mortality table. So at age 66, on average, being a man, I have about 15 years, all right, of left in my life. If I'm on dialysis today, it's 3.8 years. So I'm not denying that dialysis is life-saving, but the downside of the kidney failure and the incomplete nature of the dialysis and doing all that the kidney should be doing means our lives are cut short. And then you look here under transplant, and you see it's almost 3 times, but certainly more than twice longer life with the transplant, despite all the complications, than me staying on dialysis. So do I get my 15 years? I do not. I'm getting just shy of 10, but again, 2.5 times longer than I would with dialysis. So let's look at this in another way. You can go online if you want to look at your numbers. Emory runs a website. You just Google "I choose kidney" to get to it, and you plug in some numbers. So I didn't show you, but I had to put in my age. I had to put on whether I had blood pressure, cardiovascular disease, was I on dialysis. I answered a few of these questions. There's either looking at my death rate versus my survival rate. Since I'm more of a positive person, I pick survival. And look at me. If I say, again, I don't have hypertension right now, and I'm not on dialysis, but I put that I was on dialysis between 6 and 12 months in this model, then my survival rate on dialysis for 1 year is 81% versus 97% survival if I'm transplanted. And if you look at my 3-year data, 58% chance of living 3 years versus 93% for transplant. So if I just get on the list today and I've got 3 years waiting time, there's a 42% chance I never get transplanted because I'm dead. And that's the important part of making these decisions, is keeping our transplant window open, because I show you here the benefit of transplant, and that includes reducing cardiovascular risk. And so the transplant itself may help prevent some of these problems that I might have passed away from on dialysis. So if I add heart disease, so that's the CVD here on the far right over here, then my numbers are even worse. So 75% with dialysis, I drop a point because of the heart disease with transplant success. And then 3-year data, even bigger discrepancy here. So that's why these decisions are so important. So are there tools other than this that you can use? And I'm going to say, yes, there are. So I Choose Kidney is one tool, giving you 1 and 3-year survival. But your transplant center also has to report EPTS, so another acronym standing for expected post-transplant survival. So you enter your age, your dialysis status, diabetes, prior transplant, and it gives you a score of 0 to 100. So the purpose of this number mainly is it predicts your medical safety. So if your score is really low, like 0, I'll exaggerate, you live forever. No score predicts our death time. So I'm making my point of the difference between living forever at 0 versus dying tomorrow at 100. And that's how we use these numbers to help you make a decision of what kidneys you should accept. But the organ team and the match list makes it is they assign the EPTS, the 0 to 20 recipient who's expected to live the longest, medically safe, low numbers. They get the first dibs at the kidneys that are going to last the longest, the 0 to 20 group. So that's happening in the background with the match run. But for us, and here's the online, so you just put EPTS calculator and you'll get a website that has this interface. So again, I put in 66, that I was on dialysis a year. I don't have diabetes. I've never been transplanted. And oops, I don't know if you can see this. I had trouble. I have to move something, but my EPTS is 46. So I mentioned humorously, 0, I live forever, 100, I die tomorrow. I'm right in the middle. So typically with a score between 30 and 70 at Mayo Clinic, depending upon some circumstances, we leave that decision up to the patient. If your score, EPTS, is less than 30, then you're kind of safe. You can afford to wait for a standard kidney. You don't need to take chances, all right? Versus if your score is greater than 70, we would guide you to say yes to KDPI greater than 85 because it opens the pool of more kidneys, gets you transplanted quicker, and it may help prevent a problem that closes your transplant window. So EPTS is another tool. This is our protocol currently at Mayo, which I just mentioned. And then there's a brand new tool that just became available in the past few months. And so I'm literally showing you a HIPAA redacted kidney offer from yesterday. So there were several transplants done here yesterday. This was one of the offers. So I'm going to break this down because it helps reinforce things that I've already talked about. So this offer was from a donor after cardiac death. So they had to wait for the heart to stop. The KDPI was 81. And I mentioned before, 0 to 85 is in the normal range, okay? It was a no-risk donor, no heroin, no buying or selling sex. They were hepatitis antibody positive, NAT negative. So again, a low-risk hepatitis C kidney. They were core antibody positive, meaning if you hadn't been protected against hepatitis B, there's a very tiny risk of getting hepatitis B, but there's ways of selecting recipients where this is a safe kidney. And the recipient had been on dialysis for 5 months. The CPRA was on the higher side, 81. I told you that cutoff of 80 can sometimes make a difference. And the EPTS was exactly the same number I just showed you for me, my EPTS with some of the dialysis and hypertension assumption. So a kind of a mid-range medical risk. So when you click certain buttons on the offer sheet, it gives you some information as the transplant center. And it says, hey, in this sample, maybe we could wait for a lower KDPI. Remember, lower KDPI, younger donor, they tend to last a little longer, but not a lot of statistical difference between a 0 and an 85. So this is within the standard kidney. And this little protocol shows that this patient had a 50% chance of getting another offer of a slightly better kidney in about 5 months and a less than 1% chance of dying, all right? Versus an even better kidney, less than 30, they would have had to wait a year and 7/10 with a 4% chance of dying. So there are circumstances. This wasn't all that helpful because this kidney wasn't much different clinically as far as we're concerned than these offers. But sometimes there's a big difference, and we sometimes say, hey, it's better to wait and we'll pass on this recipient because they're going to get a better kidney offer in a very short time and their risk of death while they wait is very low. So I can't even tell you how we're going to use this because this just became available, but this is likely something that's going to allow more education for recipients to help be active in choosing. So to finish, to leave a little room for questions, my recommendations to you, DCD and DBD, yes, there's a little more dialysis with DCD, but the outcomes long-term are equal. I say yes to both. I would strongly encourage you to say yes to donors meeting risk criteria for HIV and hepatitis, drug overdoses, people that die in jail, people that buy or sell sex that die, because your risk of infection is so low and the benefit of the kidney, often with a lower KDPI, better quality kidney, is much higher. I say yes to hepatitis C positive kidneys. That's the NAT positive because the cure rate, the track record is excellent. And then consider KDPI greater than 85. So these are kidneys that had the half-life that was half as long as 0 to 85 KDPI. If your CPRA is really high, meaning it's going to be harder finding you a compatible kidney. If your EPTS, the medical risk score, is high, above 70, let's say you're having access problems on dialysis. Your heart disease is okay for transplant, but might be changing, or you have a lot of hardening of the arteries in your legs that might get worse. And these all may close your transplant window. Getting a greater than 85 can get you transplanted quicker and would be worth taking that kidney. So probably talked a little longer than I wanted to, but I'm happy to take questions and hope that you're willing to share. Thank you.
So there are some questions in the chat. Do you want to go there, or
Okay,
you
yeah.
want me to tell you? Yeah.
No. So what is the maximum time a kidney can be on ice? So you're going to get a different answer from every transplant program, but in most circumstances, you're going to stick with a 24 to 36 hour window. So even here, there's been extremes where we've gone as long as 48, and I've heard people go longer than that. But it's going to have to be a special donor, usually a much younger donor, where the donor kidney can tolerate that time on ice. So here, we generally like to get it in at 24 hours or less, but we will occasionally, depending upon the quality of the donor, go longer than that. And then Janine asked, where do you find your CPRA? Is it on the portal? So it is one of the laboratory reports, but it's under the HLA, human leukocyte antigen antibody report. I don't know if they give you access to that because it's hard for people that are in the business for years to sometimes understand the antibody. That's why we have HLA experts here at Mayo Clinic to help us. But your coordinator ought to be able, if you call or portal your coordinator, they ought to be able to tell you what your CPRA is. And then in general, if it's below 80, not likely to be a problem. And 80 to 95, 98 may extend your time a little bit, but probably not a huge problem. It's the 98, 99, and 100 that become bigger problems. And the challenge right now, we don't have a good way of getting rid of the antibody. So that's a problem that needs to be fixed. And then what's the wait time if I have a voucher for a blood type? I don't know what the voucher means. So voucher happens in the setting if you have a living donor, your donor gave, and National Kidney Registry gives you a voucher for, your blood type is A kidney, and the NKR brag that they can match 80% of the people within a year. So again, it's not a perfect system, but it's not easy question to answer because again, you're not telling me what the CPRA is and how difficult you are to match. Rarely someone is waiting for a voucher kidney because they have not had mono. And if they get a mono positive kidney, it increases their post-transplant lymphoma risk. So there's other issues that will affect the answer to that question, which I have to be purposely vague. And then do other transplant centers have to do a full workup? So you're obligated to have the surgeon, nephrologist, nutrition, pharmacy, social worker visits. That's a Medicare rule. Some of them sometimes can be done virtually. They're not allowed to pony on another center. Mayo gets away with that because of the unified team and the structure of the 3 Mayo clinics. So Cleveland Clinic, it's possible that the hospital in Cleveland and the one in, I guess, Fort Lauderdale or Hollywood, they may be able to do the same thing, but we can't work that way with Piedmont, Orlando, Miami. So those centers have to do that work on their own. As I mentioned, they will want to do their own blood typing and tissue typing because each one does it a little different. And that's another safety issue. But the EKG, the standard lab, most of that stuff can be shared between transplant centers. And I can tell you it's sometimes mandated by the insurance company. They don't allow the repeat tests. So most transplant centers are now open to that. So it's usually not the whole workup. It's a shortened version meeting these people. Do you have an estimate of KDPI over 85 shortens wait time? So historically, that's been about a year. It's been as high as 2 years, but my understanding it's roughly a year to a year and a half right now that it may shorten your wait time to getting a kidney quicker. And remember, if you say yes to greater than 85, if there's a kidney that is a 0 to 85 that matches you, you still get that kidney offer. They're not only offering you greater than 85s. The next question, if a donor has diabetes, does a recipient then inherit the diabetes? No. So, so the good news, if you're a guy and you get a girl kidney, you can still pee standing up. All right. Very important. All right. If you're a New York Giant fan and you get a Dallas Cowboy kidney, you don't suddenly become a Dallas Cowboy fan. So I do this in a little humor. It's a great question, and it's on everybody's mind on the recipient, although most people aren't brave enough to ask the question. But there was a lady in Dallas I worked with, an anthropologist a long time, was trying to convince us that there were some traits of the donor when you did a heart transplant. It isn't true in my mind. I strongly believe you get nothing other than whatever infection or cancer is in that kidney when it comes your way. So again, we've done our best to screen to make sure you get no infection and cancer, but I've already mentioned none of the infection or cancer tests are 100%. So for example, a colonoscopy, 92% accurate in detecting colon cancer, but that means it does miss it 8% of the time. So that's just an example that there's no zero risk donor. So no, the answer, you don't get diabetes from the donor kidney.
So
What are the wait
KP wait
times?
time. Yeah, KP wait
Yeah,
time.
so the KP story is a little unusual. So that historically has been a shorter than the kidney wait. So 6 to 12 months shorter, but lately we're actually seeing it a little longer. And I don't have a good answer for that yet because that's a new phenomenon. But it can be just a little bit longer where we're feeling a little more pressure, and particularly in pancreas only, trying to get those people listed as quickly as possible so that they can get the wait time. I have some acne. It's going to keep me from being able to get transplant. So there's several different skin lesions that can be problems because of infection. And when we give you our drugs, it can make them worse. So acne is one that the prednisone that we give can make acne worse. But in general, acne isn't a contraindication to transplant. But there are some people that have a version of acne where it's more systemic and much more deep. And you would have to be looked at as an individual to determine whether that's an obstacle. I will point out that occasionally antibiotics or some of the new biologics can fix that. So there's another skin ailment called hidradenitis suppurativa, which is generally under the armpits or in the fatty layers where the oil glands get infected. Again, it's an inflammatory disease with secondary infection. You generally, though, have to be infection free. There's new biologics available for that to get it under control, and then you can be transplanted. Is there a device that artificially perfuses the organ to increase viability time? There is. And that's the huge movement. So we're pumping kidneys a lot longer. So it has several advantages. So you get the creatinine, you might even get a kidney biopsy, you get urine, you get all this lab. But now when you hook up the kidney, you get a little more information about the kidney also. On top of that, when you pump a kidney, you tend to be able to extend the time that the kidney can stay out of the body, and you can do the transplant then at a more opportune time. So, I mean, I give our surgeons all the credit. They will operate at any time. And that's why our average cold ischemic time, the ice time, is less than 17 hours. So our average is really low. But the more we can do it during the daytime when we get everybody rested and stuff, I think that's for any human that's going to improve their output and reduce risk. So there are. Can we get a copy of the PowerPoint? Sure, I can talk to Pat on how that that happens, I've
And
got,
actually, we record this. So the
okay, that's
recording will be out on YouTube in about 3 weeks.
all right.
Okay.
If I'm highly sensitized, like 98 or more, if a living donor is not a match to me, yeah, that's a tough question. So, that I quoted the 80% match rate within a year. That generally is for folks that are not as sensitized as 98, 99, or 100. But what they have now, again, learning a lot about antibodies, the group that seems almost impossible to transplant are the ones that are 99.95 and higher. So, of course, most of those were rounded up to 100. But that's the group that we may never be able to find a kidney until we can get rid of the antibody. So if you're at 98, I can say it's going to be longer, but I don't have a gauge. We don't track that. There's not enough folks for me to be able to give you a good answer to that. And so in those situations, the other option is, of course, you've got your living donor. You're trying to find a living donor match back, but look at all the deceased donor options that you can to try to work it that way. The bigger the pool of kidneys, the more chance that you find a compatible kidney. Then let's see, the next question, why do O blood types have to wait longer? I don't know. So I've not heard anyone give me a good explanation. Been doing this since I asked that question in 1985 when I started. So it is the most common blood type. Historically, not as long as the B blood group, but currently it's running as long as our B blood group. So historically, O's wait about a year less than B's, but currently that's not the case. And back in the day
I'm
when
a
I
type
started,
B blood group, and I've been waiting for 5 years now, and I still haven't got a kidney. So I was wondering what was the cause for me waiting so long.
well, so I showed you earlier on the slide, the average wait for blood group B is 5 to 6 years. So it's possible that you're getting close to the top of the list, but it took that long for blood group B. And as I'm mentioning, blood group O, unfortunately, has a 5 to 6 year wait currently also. And so in the old days, O's were given to non-O's, but that went away a while back. B's now, that's shortened because some A kidneys can be used in B's. So they are taking some of the A kidneys because A's got the discrepancy as far as getting transplanted quicker. They're using some of those A's in the B blood group, but unfortunately they can't use the A's in the O's. When you get a call offered, does someone consult with you to make sure recommendations whether to take the kidney? Great question. So, the key here is we're doing our best to disclose all the important information that we use to make a decision of whether to take the kidney or not. That includes the infection serology, if it's a pediatric kidney, a dual adult kidney. If the donor died of brain cancer, certain brain cancers stay in the brain, don't travel, but that would be something we would want to disclose just so that the recipient knew about it ahead of time, would have a choice of saying yes or no. If the donor was a drug overdose, that information, again, that they're a donor meeting risk criteria is disclosed. And of course, they give you the KDPI and they can tell you whether it's a brain dead or cardiac death donor. Beyond that, that's all that we're allowed to kind of disclose. And we, on our back end, we're having conversations. So, I mentioned the first call goes to the surgeon. If the surgeon doesn't know, the coordinator calls me, what do you think? And sometimes the surgeon and I have to get on the phone and talk and make a decision of whether we take the kidney. Surgeon says yes, they call me, here's the deal. The surgeon said yes, I don't see any problems. Then we move forward and we pass that information on to the recipient. And I think that covered the questions, and we're running a little late.
And I think we're going to stop there. So thank you everybody for coming, and thank you so much, Dr. May. You covered
Great
a whole bunch
questions.
of info.
Yeah, thank you so much. And I know it's a lot, but I'm glad that we got it recorded. And please feel free to reach out to your coordinator if you have questions. We're happy to try to get them answered.
Thanks, Dr. May.
Thank you,
Bye-bye.
everybody. Take care.